Please go ahead.
Yeah. Okay. A very good evening, all. Can we all have on screen the faculty, please? Please put on your videos, whosoever has joined. So, very good evening to all the delegates who have logged in for this webinar, along with the scientific faculty, the esteemed list that we have today for today's webinar. So we have been all talking about, the gum-related associations of the diabetes, and the literature is slowly inching forward to a host of other conditions. And diabetes is a playground, I would say. I call it as a playground. It's open to all the players of different other organs and conditions to just keep on marking their strokes. So moving forward here is the topic that we have chosen is oral cancers and the diabetes afflictions. And knowing that Diabetes India is predominantly a diabetologist fraternity, so it's a good thing to be having an interactive session today from the your faculty list you have and the array of the topics that we have designed today. And can we have the introductory slide for co-moderator for us, Sagar? Oh, so that's me. So I happen to be the chairperson for this the group. Can we have Dr. Gunjan Gupta's introductory slide, please? Now, today's webinar, Dr. Gunjan Gupta, she'll be co-moderating with me. She is an active DIH member. She has an academic and clinical background almost like 12 years into the system. She is a consultant periodontist as well as HOD at the ITS Dental College, Greater Noida. She is an active faculty for implants, mucogingival hands-on workshops along with lasers. She is a live member of Indian Society of Periodontology and assistant director for a couple of other organizations that she supports initiatives. She is honored with the Global Professional Award for the year 1992 and has a keen interest in periodontal medicine as well as a content developer for JP Publishers. Over to you, Gunjan, to take it forward, please.
Thank you so much, ma'am, for the introduction. But I guess there was nobody to introduce you. So would you like me to introduce you?
No. Please carry on.
Okay. No, definitely. Why ask? You should.
Why ask?
Yes.
You should.
Yes. Because chairperson will never tell कि हाँ introduce करो मेरे को.
फटाफट कर दो, so we start the sessions.
Okay, so today we have our moderator of the day, Professor Dr. Sangeeta Dheer. She is the chairperson of Diabetes India Oral Health Group. She did her master's in periodontology from College of Dental Sciences, Davangere, Karnataka, and clinical externship program in implantology from University of Birmingham, United Kingdom. She has credentials by the International Congress of Oral Implantology and their fellow. She maintains her private practice at Faridabad and is a consultant at Max Hospital, New Delhi. Ex-core committee member, National Oral Health Program, Ministry of Health and Family Welfare. She has served Indian Society of Periodontology in various capacities, has been ex-vice president, executive member, national convener, Prenatal Periodontal Health Care Committee, assistant editor journal of ISP, ex-editor-in-chief journal of International Clinical Dental Research Organization, and was the organizing secretary of the first national symposium in India on periodontitis and diabetes. It was a collaborative event of RSSDI and ISP. She has a numerous scientific publication and has been keynote and guest speaker at several dental and medical conferences, meetings on national and international forums. We welcome you, ma'am.
Thank you, Gunjan. Please take the proceedings forward, please.
Okay, so I would like to initiate our first session or the first lecture of the webinar. So for that, I would like to invite our first speaker of the day, Professor Dr. Neema Rai. And to introduce our first speaker, I would like to invite our esteemed chairperson, Professor Dr. Vital Kumar Gupta. Can we have his introductory slide, please? Thank you so much. So, Dr. Gupta is a health and human rights activist, national convener, Pollution Council Cardiological Society of India. He has been the chairman of RSSDI Punjab Chapter 2324, member Executive Committee Cardiological Society of India 2018-22, fellowship of ISPP CSI, ACP, and IACM, Role of Honor in Table Tennis, Lawn Tennis, Badminton, and Swimming. He has been the chairperson and the organizing committee of Epicon 2014 Ludhiana, organizing secretary Mapicon Bhatinda 2014-24. He has published over 50 scientific papers, 51 chapters, several abstracts, guest lectures, and share. He has been the chief editor of API PRF monograph on pollution and health, chief editor API ICM monograph on COPD Indian perspective, chief editor API ICP monograph on respiratory emergencies, Medical Scientific Committee Epicon 2016 Hyderabad. He has been the member of JAPI DIPSI guidelines for DDM chairman API Malwa branch and editorial advisory board Indian Heart Journal. We welcome you, sir, and I request you to kindly introduce the first speaker of the day, Professor Dr. Neema Rai. Can we have her introductory slide, please?
Thank you very much, Dr. Dheer, for inviting me for this, my first exposure to dental sciences as a chairperson. And I must congratulate Dr. Bansi Sabu and Diabetes India for making this oral health group as interest group, because it is needed to percolate the awareness about dental health connection to the physical health involving almost all the organs. Thank you very much. And I have the honor to introduce Professor Dr. Neema Rai, MDS Periodontology, Professor and Head, Pacific Dental College and Hospital at Udaipur. She did her BDS in 2002 and MDS in 2009. She has a vast academic experience of 15 years of teaching UG and 11 years for teaching PG. More importantly, she has about 49 publications. So I think that tells us about her research acumen. So I invite you, ma'am, to please initiate your lecture.
Thank you, sir, for the wonderful introduction. Let's start.
Dr. Neema?
I'm
Dr. Neema?
Yeah, are you able to see?
Yeah, before you start, we would like to welcome the Joint Secretary of Diabetes India, Dr. Amit Gupta. He has joined us. Dr. Gupta, I think.
Hello, Dr. Sangeeta.
Yeah, good evening. Good evening, Dr. Amit. Dr. Neema, 2 words we will have from Dr. Gupta. Dr. Amit, would you like to just share a few moments with you?
Yes, thank you, Dr. Sangeeta, for organizing this wonderful webinar. And it is great to see Dr. Vitul Gupta, Dr. Prabhat, Dr. Girish Khurana, Dr. Lisa, Neema, Dr. Nalini. And on behalf of Team Diabetes India and Head Office, I would like to welcome all of you. As you know that we are going to have our annual conference very soon in the month of February in Ahmedabad from 13th to 16th of February. And so this webinar is again a very, very important topic. And you just know that recently American Diabetes Association has again reintroduced that oral health is equally important when you are taking care of your patients with diabetes. And Dr. Sangeeta Dheer and this interest group, that is DIOH, is doing amazing work. And this is just one webinar. And next week, next Saturday, we are going to have our in-person meeting also in New Delhi, which is again being organized by Dr. Sangeeta, and it is going to be at the Max Hospital, and where we are going to take deep dive into the connections between the diabetes and the oral health. So I wish you all the best. And with this, I will hand it over to Dr. Sangeeta to conduct today's program.
Thank you, Dr. Amit, for your words. Dr. Neema, can we have your presentation, please?
Is it visible? I hope it's visible.
Absolutely visible. Please initiate.
So my topic is diabetes and potentially malignant oral conditions, which will include the introduction, prevalence, history of relation of diabetes and cancer, along with head and neck cancer with focus on oral pre-malignant and malignant lesions with current evidence. So going into the intro and prevalence of diabetes first. As we all know, it's taken from a Greek word actually, which means see through, and mellitus means sweet. and which results in persistent hyperglycemia. Classification, yeah, as we know, it is insulin dependent and non-insulin dependent.
Dr. Neema, can I interrupt? Please share your full screen, please.
Yeah, ma'am, I'm sharing full screen actually. Is it not visible for you?
No, it's the slides coming on the slides. Just go to the bottom side and just make a full screen, please.
Yeah, it's for me, it's full screen itself, ma'am. I don't know. This
Ma'am, just stop sharing and make it a full screen and share it again, please.
Now reshare it and make it full screen.
Yeah.
Sagar, please help in case.
So is that visible? I need to share it.
Yeah.
Is it okay now, ma'am?
No, we are not able to see your screen, ma'am.
Ma'am, go to Zoom and share it again.
Yeah, now?
Now
Yes,
share.
it is started sharing. Yes, that is perfect.
Perfect. Just go ahead, please.
Yeah. So, as we saw, diabetes was to seep through and mellitus was sweet, and effects over time, it can lead to serious damage to the body systems, especially nerves, blood vessels, kidneys and eyes, with the complications we know of neuropathy, nephropathy, retinopathy, microangiopathy, and the CV, the heart diseases, actually, especially the sixth. I'm sorry, I'm not able to go to the next slide with screen share, full screen. I don't know, there's some problem with this. So is it okay if I do the slideshow itself?
Ma'am, just click in the center of your PPT, then you can click, you'll be able to go to the next.
Yeah, right. Thank you. So when you come to the relation of diabetes and oral mucosal diseases, especially because of the systemic impact diabetes, which impairs the wound healing, immune responses, and also increasing inflammation as a whole, which influences the oral tissues. So this persistent hyperglycemia has led to chronic low-grade inflammation, which will contribute to the progression of the oral mucosal diseases. And of course, the decreased immunity makes the oral mucosa more vulnerable to infections and delayed healing. Now, coming to the prevalence of potentially malignant lesions in diabetics, diabetes mellitus is, of course, a global health problem whose worldwide prevalence is increasing progressively, and the number of patients have almost doubled from 153 million in 1980 to about 347 million in 2008. And in 2021, an estimated 537 million people worldwide had diabetes, which is almost 10.5% of the adult population according to WHO. So the prevalence of diabetes is expected to increase to 783 billion by 2045, as has been estimated by prestigious international organizations. So the prevalence is going on doubling. And also oral cancer is a growing global health problem with about 354,864 new cases. And above them, about 1 lakh patients death per year. And a 5-year mortality rate of 50%, which is directly related with the tumor. And till now, as we have seen, only one meta-analysis is published. That is why we don't get much in the literature about this. Has documented the increased risk of oral cancer and oral potentially malignant disorders, which includes leukopenia. Our oral potentially malignant is these, and some inconclusive evidence also for oral lichen planus and actinic cheilitis, which are also both relevant oral pre-malignant lesions, but not documented in this 2015 meta-analysis. Now, the higher risk of oral pre-malignant diseases is, as we have seen, leukoplakia, erythroplakia, oral submucous fibrosis, lichen planus. These were documented that in diabetic patients, these oral pre-malignant diseases were higher, and this might be because of chronic inflammation and impaired healing. Because impaired healing in oral pre-malignant diseases exacerbate diabetes exacerbates the wound healing issues in patients undergoing treatment for oral premalignant diseases such as biopsy surgeries or laser ablation. Especially when they go for biopsies, their wound healing might be delayed. In oral lichen planus, which is a OPMD, it is strongly associated with diabetes. What happens is hyperglycemia might trigger the lichenoid reactions, potentially leading to malignant transformation in rare cases. And one more is the oral submucous fibrosis, where diabetes-induced chronic inflammation and oxidative stress can aggravate the OSMF progression and symptoms. So especially oxidative stress and inflammation lead to this. This is just going to the history of relation of diabetes and cancer. Some cancers like liver cancer, pancreatic cancer, breast cancer, bladder, colorectal, all these were recorded to have a higher incidence in diabetics, whereas some cancers like prostate cancers were less likely. And cancers with no clear association were also found, where a clear association has not found with diabetes, like our current topic, oral cancer. And the risk of cancer may be higher for people with early onset type 2 diabetes, especially those with a higher BMI at age 18 itself. Now, the possible reasons for link between diabetes might be because of the shared risk factors, like common risk factors like obesity, aging, diet, and physical inactivity, or might be due to hyperinsulinemia, which is common in people with type 2 diabetes, and it can activate insulin receptors that promote cancer cell growth and survival. Also, cancer and diabetes both are related to inflammation, as given by Jones in 2010. Now, especially coming to the head and neck part, head and neck cancers with focus on oral premalignant and malignant lesions. Diabetic patients had an increased risk of cancer, head and neck cancers, and subsets like oral cancer, while in other studies, this risk was decreased, sorry. Now, this decreased inverse association might be due to metformin use among diabetic patients. This was referenced by Carvalho et al. In 2016. And recently, increasing evidence has been presented for the potential anti-cancer and anti-metastasis effect of metformin. Basically, when patients are on anti-diabetic therapy like metformin, the cancer incidence might have been reduced. While tobacco, alcohol, and other risk factors like infection, inflammation, and infection with the oncogenic human papillomavirus are estimated risk factors for head and neck cancers, emerging evidence suggests that abnormalities of glucose metabolism and diabetes also play a role. This evidence was given by Ravara et al. In 2015. Therefore, if diabetes is associated with an increase in the risk of cancer, this may have a tremendous effect on health worldwide. So, an early Hungarian retrospective study analyzing 610 inpatients with oral cancer compared to 574 controls found that diabetes was present in 24.3% in the oral cancer group versus 11.1% in the control group. It was statistically significant, but on the other hand, another cohort study conducted in the black and white US veterans with a large sample size of about 4 lakh individuals suggested that a significantly lower risk of oral cancer in the diabetic patients. So there were conflicting evidences, and current evidence, which includes meta-analysis and systemic review, given by Ramos Garcia et al. In 2021. In this, the objective was to evaluate current evidence for the prevalence and risk of oral cancer and potentially malignant oral disorders among diabetic patients. And they evaluated PubMed, Embase, Web of Science, and Scopus studies published before November 2019. The meta-analysis was conducted and a total of 1,489 studies were found. 116 were analyzed in full text, 52 included in qualitative synthesis, and 49 were meta-analyzed. And in this, they found that patients with oral cancer and diabetes, the association was about 0.25%. That is 250 per 1 lakh diabetes patients had a greater chance of oral cancer among the diabetes patients. And also they had a higher mortality rate. It was a significant, the significance was high in this. Whereas when we go to the pre-malignant lesions, leukoplakia had a pooled prevalence of 2.49%. That is about 2,490 per 1 lakh diabetes had the prevalence. Whereas for oral lichen planus, the prevalence was, pooled prevalence was 2.72. That is about 2,720 per 1 lakh diabetes patients. Whereas for erythroplakia, the pooled prevalence was little low. That is only 0.02%, 20 per 1 lakh patients with diabetes mellitus had erythroplakia. So in conclusion, patients with diabetes mellitus have a higher prevalence and greater chance of oral cancer and oral pre-malignant diseases development in comparison with non-diabetic patients. So we can come to the conclusion that the prevalence is higher of oral cancer and OPMD in diabetic patients in comparison with non-diabetic. Also, in addition, patients with oral cancer suffering from diabetes have a higher mortality compared to the non-diabetic patients with oral cancer. So this relationship between diabetes and OPMDs underscores the importance of early detection, preventive strategies, and comprehensive management to minimize the risk of malignant, which will be covered by the next speaker, I guess. Yeah, thank you, ma'am. Hello.
Thank you.
Yeah, Dr. Gunjan, kindly.
Yeah, thank you so much, ma'am, for such an excellent deliberation. Dr. Gupta, would you like to add on something to ma'am's lecture? Hello, sir.
Sir, please put on your mic. Dr. Gupta, yeah.
Yeah.
Diabetes and oral cancer may not have substantial evidence as of today, but I think your oral group is going to stimulate the young researchers to find out the link. And especially in Indian setup, when there is cluster of risk factors like tobacco use, other things, chronic irritable things in the mouth, the relationship between diabetes and physical health related to oral health becomes really important. And I must congratulate Diabetes India for making this health group to make people aware. And we should strive to make people aware about the link of oral health to physical health, focusing on diabetes. Thank you very much, ma'am, for giving us insight about the link of oral cancers with diabetes. Thank you very much.
Thank you so much, sir, for your valuable inputs. And thank you once again, Nima ma'am, for your excellent deliberation. Over to you, Sangeeta ma'am.
Dr. Gunjan, may I add something?
Definitely, sir. Most welcome, please.
Okay. Good remarks by Dr. Vitul Gupta and excellent presentation by ma'am. So I was wondering also when I was going through the literature, I just spoke to Dr. Sangeeta ki I couldn't find the prevalence of oral cancer with diabetes, any of the textbook. So maybe it is in the primitive stage. But one thing which madam told us that incidence of prostate cancer is less with diabetes. So she is true, but that is true for Western population. If you look for the Indian data, it is almost as good as other cancers, around 1.5%. In Western population, prostate cancer incidence is less in diabetes. I don't know the reason behind this. I couldn't find the reason. But this is the only cancer which is less in Western population, prostate cancer in diabetes. Whereas in Asian population, it's not. It is almost double the incidence. So this was one point which was I am going to add to it. She told us that incidence of prostate cancer is low, but that is only in Western population, not in our Indian population. And as Dr. Vitul said, that is very difficult to pinpoint the cause. In my practice of last 30 years, I have not been able to single out even a single patient of oral cancer with diabetes alone. Most of the times they are chewing tobacco and recently I had a patient who was diabetic, but he was taking some gutka for last few many years. So maybe diabetes was one of the provocating factors, but that irritating factor in the mouth, maybe it is gutka or some cigarette smoking or maybe some tooth irritation, leukoplakia, the early type. So these things needs to be again researched in coming time. So that's all.
Absolutely. Thanks, Dr. Khurana. Dr. Gunjan?
Yes, thank you so much, sir, for your valuable inputs. Yes, over to you, Sangeeta ma'am.
Yeah. So we now move on to the next lecture of the evening. May we have the chairperson for the next talk, Dr. Lisa Pathak, please. So Dr. Lisa Pathak is a professor and head Department of Periodontics, Government Dental College, Dibrugarh, Assam. She's an author for a couple of publications of Power of Regeneration, Anti-Plaque Agents, and Tales of Tender Minds. She's a social activist also that I know her for so many years. She is a founder of Tender Mind, a forum dealing with mental health care for students of dental college, and the brilliant work she's doing at her end. She has been into academics for the past 20 years and a postgraduate guide as well, and is a member of British Society of Periodontology. Over to Dr. Lisa to introduce the next speaker, please. Can we have the bio sketch for the next speaker? Dr. Lisa.
Hello, everyone. Greetings from the tea city of Assam. Now moving forward to the next speaker of this webinar today, and he is Dr. Prabhat Agarwal from Agra, and he is going to speak on the topic of diabetes and oral cancer, the risk burden in India. An erudite scholar of high repute, Dr. Prabhat is a gold medalist. He holds a postgraduate diploma in diabetes from London, FRCP from Edinburgh and Glasgow. He is fellow Diabetes India, fellow and governing body member of Research Society for the Study of Diabetes in India. His H index is 30. So with this, I would like to invite Dr. Prabhat Agarwal for this session. Let's hear his valuable input on this very interesting topic. Over to Dr. Prabhat with best wishes.
Thank you, ma'am. Thank you, Lisa ma'am, for a nice introduction. And of course, at the outset, I would like to thank you, Dr. Sangeeta ma'am, and the Diabetes India, and other my co-speakers and the chairperson of this today's evening. Greetings from the Agra, city of Taj. So basically, I was allotted topic to what is the real burden of diabetes and oral cancer and what is the relation between both of them. So I will try to, as Bitul Gupta sir has already told, that it is a little bit tough topic for me, especially because I am not an oral physician, and it is very difficult, but I try to do justice by searching literature, and I am very I have no restriction or jhijak to say that I took help of my postgraduate student for making these slides. So I will try. Just 1 minute. My slides are moving.
Yes, sir.
Okay. So at the introduction, as my previous speaker mentioned, that oral cancer and diabetes are the highly prevalent among the Indian population and are the part of top 4 non-communicable diseases, which are responsible for the mortality as well as the morbidity. Annually, there are approximately more than 77,000 cases and 52,000 deaths because of the oral cancer. That's why it is very important. And overall, it is accountable for almost 1/4 of the global incidences. So it is about the Indian. When we talk about the diabetic population, Indian population recent ICMR India study, which was published last year in the Lancet, according to that study, 101 million people are in India suffering with the diabetes, and also almost 136 million people are suffering with the pre-diabetes. And we know that if I think more than 90% of this pre-diabetic population definitely will going convert into the diabetes in the next couple of the years. So that's why the total burden is very high. There's a term when I was found the literature the term was the diabetic oncopathy. As we know, the complications of the diabetes is called neuropathy, nephropathy, retinopathy. So I found this term oncopathy looks very fascinating to me. As the higher risk of developing number of cancers among individuals diabetes, so including pancreas, liver, gynecological cancers, colorectal cancer, oral cancer, breast cancers. So this is also a emerging complication of the diabetes. Of course, tobacco use, elevated glycosylated hemoglobin, hypertension are the risk predictors. And it is seen in few studies that risk of oral cancer increased almost more than double when HbA1c level more than 9, even after adjusting the co-founders. So it is seen when we did the head-to-head comparison. I found in one meta-analysis it was seen that whether if they are using tobacco use or whether using hypertension, but if blood sugar is raised HbA1c more than 9, then almost there are 2 times chances of developing oral malignancies. Recent literature also suggests that prevalence of oral cancer is 0.2 to 0.25% patient with diabetes. And we know the huge number of the population of the diabetes in India. So that's why the overall prevalence of oral cancer is very important. Diabetes may lead to the development of cancer through oxidative damage, leading to accumulation of DNA mutation or through immune dysfunction. Although fully not understood, some plausible mechanisms linking diabetes to cancers are hyperglycemia, insulin growth factors, and some other chronic inflammation. We know that diabetes is a chronic inflammatory condition. So hyperglycemia and chronic inflammation and insulin growth factor responsible maybe for this possible mechanism. Recently, it was seen that both urban and rural areas, the problem of diabetes has increased rapidly. And the current prevalence of diabetes is 11.4% in India, and pre-diabetes is 15.3% in India. When you further classify this prevalence of diabetes in rural as well as the urban, so almost 10 years ago, it was definitely more in urban population, but nowadays it is going parallelly to the urban population, the rural area also. No, we know that increase in type 2 prevalence could be attributed to rapid lifestyle changes that occurred over the past few decades, including unhealthy eating habits. Thanks to Zomato, thanks to Swiggy, we have new generation has also increase of refined cereals, fat, salt, sugar, and low levels of physical activity because of Blinkit. So many apps, so many because of internet help. Increase of we are keep on increasing healthy eating habits and physical activity is practically zero. An increase in diabetes has also been associated with various exposures such as smoking, depression, built-in environmental pollutants, short sleep duration. Recently, it is seen in so many studies as insomnia or the short sleep duration because of this Netflix, G5, web series, pollution, endocrine receptors are responsible for this diabetes. When we look for the epidemiology of the oral cancers, according to 2018, I found this was the latest statistics over the cancers. Oral cancer is a incidence ranks 17th over the worldwide, and the worldwide incidence of oral cancer is 2% with a mortality rate of 50%. So you can see mortality is very high, means every second patient is who is suffering with the oral cancer is dying. So oral cancer is also very common in developing countries like us. However, in recent years, there is an increasing trend due to change in people lifestyle. And the South Asian population like us, oral cancer is the most common type of cancers, and almost 25% of the new cases of the oral cancer is seen every year. According to Globocon 2018 report, oral cancer is the second most frequently occurred cancer in India with a mortality of 9.3%. Among males, the most frequent type of cancer is oral cancer, followed by lung cancers. The widespread use of moist stuff held between the buccal mucosa, gingival lesion, and the increased risk of oral cancer. Associated with this practice explains why buccal mucosa is common sight in India and the Southeast population. Now, when we combine diabetes and oral cancer, both diabetes and oral cancer are rapidly growing public health issues in developing countries. A meta-analysis carried out by Romas, Cressy et al. Reported a pooled prevalence of 0.25% oral cancer in more than 3 lakhs patients with diabetes. A retrospective case control study performed at a tertiary care center in South India to assess the frequency of oral cancer among the diabetic population. And the finding of this study was that it was found that individuals with HbA1c value greater than 9 had twofold higher risk of developing oral cancer than other patient type 2 diabetes mellitus. And tobacco and hypertension are also identified as oral cancer risk factors in patients who are suffering with the type 2 diabetes mellitus. So diabetes population, if they are consuming, if they are having tobacco users, if they are having hypertension, definitely they are more risk to develop oral cancers. These are some common risk factors which are responsible for the oral cancers. Of course, there are some modifier factors. Sorry. Some are non-modified factors. Among the non-modified factors, non-modified factor means the factors which we cannot rectify, which we cannot improve, or we cannot change. Aging, of course, gender, genetic factors, ethnic difference. These are the factors we cannot change. But modifier risk factors are there. Dietary factors, we can change our dietary pattern. Tobacco use, we can stop using this tobacco, and alcohol intake. Of course, these are the factors which we can, if we have risk factor, then we can afford, we can change this, or we can stop using this molecule with these things. There are also some other risk factors like infections and also socioeconomic factors. So these are the few common risk factors are essential for the diabetes as well as the oral cancers. When we talk about the non-modified risk factors, especially the age and gender, the prevalence of both diabetes and cancers are known to increase with the increasing age. And historically, diabetes occurred predominantly people more than 65 years in developing economies. However, in India, studies have reported the onset of diabetes commonly occurs in younger age. For the last, when I was doing MD, almost 15 years ago, we used to see hardly any patient in a year who was having less than 35, 40 developed diabetes. But nowadays, it is very frequently that every day I used to find out, diagnose a patient of diabetes 24, 25 years. And yesterday I who developed diabetes type 2. So it is very rampant to develop diabetes in the youth, especially in Indian population. Oral cancers, of course, is a disease of the adults. Peaking age is 60 to 90. And the global prevalence of diabetes is higher in men than the women. That's why oral cancer is more prevalent in male and than the females. There are some genetic factors. As we know that type 2 diabetes is a polygenic disorder with many susceptible genes. There are some individuals who are suffering with the Lee-Fraumeni syndrome, Fanconi anemia, Bloom syndrome, have also reported to have increased susceptibility to cancers. When we talk about the ethnic difference, the individuals of cystic ethnicities are more prone to develop diabetes as well as the oral cancers. When we look for the modifier risk factors, dietary factors are very important to play a role in both diabetes as well as the cancer prevention. And urbanization and modernization have changed the dietary pattern of Indians to consumption of high caloric food and food high in the fat. Increased consumption of fruit and vegetables, low fat products, and whole grains has been associated with lower risk of developing diabetes. Similarly, high consumption of fruits and vegetables has been shown to reduce the risk of oral cancer due to presence of carotenes, vitamin C, antioxidant, and fiber in the fruits and vegetables. So both consumption of fruits, vegetables are can reduce the risk of the diabetes as well as it can reduce the risk of the oral cancers. Tobacco consumption, especially cigarette smoking, is very notorious to develop diabetes and oral cancers. And it is seen that association between cigarette smoking and development of diabetes is already proven. And the health professional follow-up study conducted among more than 40,000 American health workers, and it was reported that smoking, if person is smoking more than 25 cigarettes per day, had a related risk of incident diabetes of 1.94. When we talk about the alcohol consumption, we know alcohol is a very considered carcinogenic to especially the human being and has been associated with cancers of the liver, oral cavity, esophagus, pharynx, as well as the larynx. And when it is seen, especially in the Uttar Pradesh or the this Rajasthan and this belt to central India, it is seen that people are consuming this alcohol as well as the tobacco synergistically, and it is seen that if you are combining both, there are more causation of the oral cancers. Why it is so? Because alcohol acts as a solvent and increases the membrane permeability to the carcinogen to the mucosa. So if patient is consuming both alcohol and tobacco, it is more dangerous to develop malignancies. Alcohol also plays a role in development of diabetes, and it is a meta-analysis which was conducted in diabetic patient. It was seen that peak risk reduction at the 24 gram per day among women and 22 gram per day among men compared to those who did not consume alcohol. Definitely, so the result of this study that risk of diabetes increase above these levels of the alcohol. So alcohol, tobacco, both are responsible for the diabetes as well responsible for the oral cancer development. When we talk about the risk factors, there are some viral factors, some viral infections are responsible for the diabetes. One is the hepatitis virus, epstein virus, human papillomavirus, which are responsible for the oral cancers. And recently it is seen that patients who are suffering with diabetes, if they have a specific factor for the HPV-16 positive head and neck carcinomas. Social factors also essential for the development of the diabetes and the oral cancers. This is the biological link between diabetes and oral cancers. We know that diabetes is responsible for the hyperinsulinemia, chronic inflammation, hyperglycemia. So because of all of these, they all ultimately leads to carcinogenesis. Type 2 diabetes is related to increased secretion of insulin resulting in hyperinsulinemia, and hyperinsulinemia has been shown to associate breast, pancreas, colon cancers. Why it is so? Because insulin growth factors plays a very important role. Another is the hyperinsulinemia increases IGF-1 in the bodies, and both plays very important role in the to develop the malignancies. Another thing is the unregulated signaling of the insulin receptors, and it is hypothesized that hyperinsulinemia promotes carcinogenesis by stimulating the proliferating pathways distal to insulin receptors. And insulin also play a very anti-apoptic role, probably through the phosphatidyl 3 kinase extracellular signal regulated protein kinase pathway in the HAPG2 cells. So both ways, unregulated signaling of insulin receptors as well as the IGF plays an important role to develop malignancies. Hyperglycemia is also known promoter of carcinogenesis. We know why it is so because hyperglycemia can lead to excessive free radical formation responsible for the reactive oxygen species and ultimately going to promote carcinogenesis. Chronic inflammation is again very important, play a role in the carcinogenesis. We know that poorly controlled diabetes may lead to development of some pro-inflammatory markers like cytokines in the form of the interleukin 6, interleukin 1 beta, interleukin 8, CRP, and ultimately these are essential to cause carcinogenesis. TNF alpha activates MAPK and NFK beta and promotes proliferation of the malignant cells in the metastasis. Various studies also shown the presence of elevated TNF alpha, interleukin 6, interleukin 1 beta, interleukin 8, C-reactive protein in the saliva patient with oral cancers, and high levels of C-reactive protein also been implicated in the prognosis of patient with the oral cancers. So, do diabetes, metformin, there's a risk to progression. Now we have so many studies tell that metformin is a very common drug used until unless it's a contraindicated use in the every armamentarium of the diabetic prescription, and it is seen that it is associated with improved cancer prognosis. There are some factors: radiation chemosensitizer, mTOR pathway inhibitor, activates MPK pathway in tumors, decrease circulating insulin glucose. These are some mechanisms why which metformin can play a role in the reduction of the cancer. This study was published by me and my colleagues from SM Medical of Agra. It is very noise in the for the last 10 to 15 years that pioglitazone is associated with bladder malignancies. So finding of this study was that pioglitazone was found to be effective and safe in managing hyperglycemic, especially in diabetic population, and we did not observe any increased risk of bladder carcinomas in pioglitazone exposure. And there was no association with the cumulative dose and duration of pioglitazone therapy. Another thing, whenever we use the insulin, it is always said that insulin may be the carcinogenic. So it was a study which was published in 2011. This study was used in with the patients who were having insulin glargine, and it was seen that glargine insulin was associated with lower risk of malignancy in general in compared to the human insulin. So again, you can see in this slide that insulin is not a carcinogenic. So I want to end my talk. Take home message: diabetes increases the risk of oral cancer through several mechanisms. Hyperinsulinemia, insulin resistance, hyperglycemia, inflammation may link diabetes, oral cancers. And important pathologies are developed with high prevalence such as periodontitis, alterations, salivary flow, fungal infections, oral cancer, oral potentially malignant disorders may be the responsible. And patient with oral orophageal cancer might have a poor survival if they have pre-existing diabetes. So with this, thank you for the patient's hearing.
Thank you, Dr. Prabhat, for that excellent lecture showcasing the basics to a part of the pathogenesis. And we do have the next speaker lined up for pathogenesis. So thank you so much for your enlightening lecture. Thank you, Lisa, for chairing the session. Over to Dr. Gunjan for the next lecture, please.
Okay, so starting with the next lecture of the evening, may I please call upon Dr. Girish Khurana, the chairperson, the next chairperson of the evening. May we welcome you, sir? So, yeah, Dr. Khurana is a founder and medical director of Vidya Medicare Center, Delhi and NCR. He completed his MBBS and MD medicine from PGIMS Rohtak. He is the secretary RSSDI Delhi chapter, tutor for NDEP program in the field of diabetes. He has almost 35 publications in index national and international journals and chapters in textbooks. We welcome you, sir. And I request you to kindly introduce our next speaker of the day, Professor Dr. Esther Nalini.
Thank you, ma'am, for your kind words. At the outset, I thank Dr. Sangeeta for including me this very important webinar on oral health. And I have the privilege to introduce our next speaker, Dr. Malini, who will be speaking on pathomechanisms of the same disease which we are discussing and has been elaborated well by the previous two eminent speakers. So Dr. Nalini is a graduate from the Tamil Nadu Government Dental College and Hospital, Chennai in 2001, and she did her post-graduation from Chennai in 2005, and she has completed her master's in counseling psychology in 2024, and she is currently pursuing doctoral studies in oral health, and she is a passionate teacher for more than last 19 years, having various publications and has given more than 20 guest lectures, and she is a member board of studies of postdoctoral fellowship at Tamil Nadu Dr. MGR Medical University, and her area of interest is oral health education, preventive and surgical periodontal therapy, and we'll learn more from her in her presentation on pathomechanisms. So the stage is yours, ma'am. Is hello?
Dr. Nalini, we can't hear you.
I think her mic is off.
Dr. Nalini?
Ma'am, you're not audible.
Dr. Nalini, please switch on your mic, please.
Ma'am, we can see your slides, but we're not able to hear you.
I think you can call her if you have her number.
Ma'am, please check if any Bluetooth device or any wired headphones are connected.
Yes.
Yes.
Checking on just a technical glitch which we each time all of us get caught. So just give us a few moments.
Yes, ma'am. We can hear you. Just speak a bit.
Can you hear me now?
Yes.
Loud and clear.
Okay, ma'am.
Please share it full screen, Dr. Nalini.
Full screen?
Yeah.
Yes, ma'am. Yes, ma'am. Can you see the screen slides?
Not the full screen. Sagar, can you help her, please?
1 minute, ma'am.
Yeah, she have not made it full screen once.
Yes, ma'am.
Yes.
Perfect.
Yes. Okay, ma'am. Thank you. So good evening, everyone. I'm sorry for the glitch. So I'm going to be talking about the pathomechanisms associating diabetes and oral cancer. So actually, these two diseases, diabetes mellitus and cancer, are very common now and very important diseases. And they have a complex and heterogeneous etiology. And the interlinking is also quite obvious, and it can be direct or indirect, and could be because of shared risk factors. So we saw that so many evidences have been shown already. And it has been found that diabetes seemingly exerts a remarkable influence downstream on the risk of mortality in people with cancer, rather than an upstream risk of incident cancer, as evidenced by the following outcomes. And the attributable fractions due to diabetes were larger for cancer case fatality and total mortality than for cancer incidence. So these are some available evidences which I think ma'am shared with us earlier. And the possible link and the strong relationship between diabetes and cancer and the co-occurrence has been elucidated by the various studies, and the American Oncology Association and the American Diabetes Association have issued a statement regarding the possible links between cancer and diabetes, which our earlier speaker actually explained. So today in the pathophysiology part, I'm going to be talking about the biologic links, which is about the hyperinsulinemia, hyperglycemia, insulin resistance, and chronic inflammation, which are common between these two diseases. So for cancer, we require a complex process, which is divided into initiation, promotion, and progression phases. And various factors can influence this. A plethora of cancer types have been documented to be remarkably linked to diabetes. And there is also a reverse causality where cancer has been found to cause diabetes. And the paths have been now tracked on, and some light has been thrown in terms of the factors like hyperglycemia, hyperinsulinemia, insulin resistance, chronic inflammation, and immune system dysfunction, which have been elucidated as factors responsible for this link. So in the pathophysiology context, we have certain main classical actors like hyperglycemia and chronic inflammation, hyperinsulinemia, immune dysfunction, and dyslipidemia, obesity, and all already been proven. And then there are new emerging actors in this relationship as well, which include our microbiome and epigenetics. Now, the basic biologic mechanisms linking was already explained by the speaker. So I would just look at the relationship between hyperglycemia and hyperinsulinemia. Hyperglycemia seems to be feeding the cancer cells, and there is an early shift in the kind of metabolism. There is a metabolic hallmark of cancer cells where you have a increased or enhanced glucose uptake, and which can fuel the tumor growth. Now, the relationship between hyperglycemia and diabetes is actually a two-directional one. Now, when comparing hyperglycemia and hyperinsulinemia has been observed to develop quite early in type 2 diabetes patients in response to hyperglycemia. And it also may be present in type 1 diabetic patients after exogenous injection of insulin. So here it has been considered classically that hyperglycemia could be a subordinate and hyperinsulinemia as a primary causative factor as a risk for cancer. Now, the link between diabetes and cancer is actually denoted by a double-headed arrow. And so here is just a summary of the various mechanisms that could contribute to increased cancer risk in diabetic population. So this is just a gist of what is all involved. The changes in insulin-like growth factor, adipokines, the inflammatory cytokines, and the metabolic alterations, including hyperglycemia, which can lead to the hallmarks of cancer. So hyperglycemia is considered actually a key player. Now, this hyperglycemia could be having an effect on cancer through direct effects as well as indirect effects. So the direct effects are through growth factor signaling, and which can accelerate the cell cycle. And an initial accumulation of reactive oxygen species will enhance mutagenesis. But later on, a secondary selection of clones and decrease in the ROS production can ensure survival of the cancer cells. And again, there is an upregulation of glial cell line derived neurotropic factors, and also the Wnt-B-catenin signaling pathway also favors the proliferation of cells. Now, the indirect effects could be increase in levels of insulin as a result of the hyperglycemia, or insulin-like growth factor 1, inflammatory cytokines, as well as a decrease or a diminished immunologic surveillance, which is also observed with hyperglycemia. So these are the ways by which hyperglycemia directly or indirectly causes its effects. Now, coming on to the link between hyperglycemia and cancer-associated Wnt-B-catenin signaling. So on the left, what we see is normally when there is no hyperglycemia or Wnt signaling. In such cases, what happens is there is a silencing of the Wnt target genes. So, and that is by the co-repressor complexes like TCF7L2. So it is just there, and the beta-catenin is bound to the plasma membrane. Now, on the first picture on the right, when there is only hyperglycemia, the beta-catenin still remains attached to the plasma membrane. Co-repressor is still inhibiting the Wnt target genes, but you have a little bit of an efflux of P300 in the cytoplasm into the nucleus as well. On lower beneath the third picture, when there is only Wnt signaling, there are certain changes that would happen along with the presence of P300 in the cytoplasm and the nucleus. The beta-catenin, which was bound to the plasma membrane, has now got into the cytoplasm, but it has not got into the nucleus. But when you have hyperglycemia along with Wnt signaling, that is when we have all the other changes, more of effects of P300, influx of P300 proteins into the nucleus as well as cytoplasm, and there is going to be a beta-catenin LEF1 binding, the interaction then which gets into the nucleus and goes and replaces the co-repressor molecule. So there is going to be a transcriptional activity in the target genes, the Wnt target genes. So this is what is happening in the cellular level when you have hyperglycemia. Now, glucoaddiction, and there is a recycling of the glucose molecules. What happens is when you have a cancer cells, there is a shift, right, which is found in the kind of energy upregulation. So glucose becomes the main source of nutrition in the cancer cells. So there is a increased glycolytic flux. Now, this glycolytic flux, increase in the glycolytic flux. Now, there is this glucose, which is found in greater numbers. When glucose enters, it renders the ATP, which is denoted with the blue cylinders, the redox power, the NADH, and also anabolic intermediaries, which are given as black dots in the first picture on the left. So this enhances the nucleotides, lipid, and amino acid production, which form the building blocks for nucleic acids, proteins, and membrane during proliferation. So glucose hence plays a very important role in supplying or production of the basic building blocks for the proliferating cells. Now, there is actually a parasite strategy that has been observed. Like the cancer cells ensure high glucose supply through enhanced hyperglycemia, and vice versa, hyperglycemia favors tumor growth. So this is kind of a parasite strategy, which we can see in the picture on the right side. So they are like the cancer cells act like a parasitic strategy where they use as well as they enhance the production of glucose for their use for them to survive. Now, there are various hyperglycemia associated risk factors which alter the normal cellular system. Now, this alteration in the normal cellular system can happen at 3 levels. It can happen with the DNA, where you have the accumulation of advanced glycation end products, which definitely are going to damage the DNA. And there is an increase in the reactive oxygen species, which breaks down the DNA. There is mutations, so there is going to be an aberrant expression, and the DNA repair doesn't happen. as well as epigenetic modifications also occur. Now, this leads to dysregulation of oncogenes and tumor suppressors. Now, coming on to the RNA, there is aberrant regulation of RNA, mRNA, microRNA, and the long coding RNA. So, thereby there is going to be transcriptional modification. Now, in case of the proteins, there is going to be a post-translation impairment. The post-translation modification is going to be inhibited. There could be an upregulation or downregulation of certain oncoproteins. There is going to be an upregulation of inflammatory proteins. And so this can lead to cancer progression. Now, here is a multi-dimensional model which shows the relationship of obesity, hyperinsulinemia, and the role of insulin-like growth factors. So this was explained by our previous speaker as well. So mainly the two postulated pathways in which hyperinsulinemia acts is one through the IGF-1 axis. So there is going to be it has been found that there is a modest correlation with higher circulating levels of IGF-1 and cancer. Now, hyperinsulinemia leads to increase in IGF in the body, and increased insulin levels decrease the production of insulin-like growth factor binding protein. And this can lead to increase in the levels of free circulating insulin-like growth factors. Now, this circulating insulin-like growth factor binds to the IGF-1 receptor. And this resembles the insulin receptor. And this triggers a cascade through the AKT pathway and then promotes cell proliferation, survival, and invasion. So this is the way that the IGF, which results because of hyperinsulinemia, plays an important role. And it's been found that the salivary levels of IGF and the concentration of IGF was about 117% higher in oral cancer patients. So hyperinsulinemia promotes carcinogenesis by stimulating the proliferating pathways distal to the insulin receptors. And insulin as well has an anti-apoptotic role, probably through the phosphatidylinositol 3 kinase pathway. So you do not have the apoptosis also happening. So coming on to the chronic inflammation, when there is an inflammatory mediator, when there are inflammatory mediators at high concentration because of chronic inflammation, there comes a state of a permanent pro-inflammatory condition. Inflammatory cytokines like interleukin-6, interleukin-1 beta, interleukin-8, and C-reactive proteins have proven to be playing a role in carcinogenesis. And this can activate TNF-alpha, can activate the MAPK pathway and enhance the proliferation. So when there is chronic inflammation, it actually creates a pro-oncogenic microenvironment, which favors proliferation and survival of the cancer cells. Now, coming on to the changes in the metabolism. So during the progression of cancer, tumor cells are known to switch their energy source from mitochondrial oxidative phosphorylation to a less efficient glucose-dependent glycolytic pathway. And this is called as the Warburg effect. And this is a hallmark of all types of cancers. And so there is an increased glucose uptake and increased cancer risk, which has been associated with high calorie intake. So this is how your diet is linked to cancer. And so the cycle on the right side shows the changes. So when you have glucose, it undergoes glycolysis inside, and you have pyruvate and the formation of lactate, which plays a very important role. This fermentation process plays a very important role in cancer cell survival. Now, how is it? So in case of the immunologic aspect of it, so you have, when you have the Warburg effect, more production of lactate, there is a decreased expression of MHC1. Now, this MHC1 is going to help your immune cells to identify. So immune surveillance to happen. So when there is a lesser production of MHC1, which is mediated by this Warburg phenomenon and the glycolytic pathway, the tumor cells escape the immune surveillance, and that's how they think. But when there is a shift, there is going to be a ERK5 modulated expression of MNC1 when there is a shift in the type of energy production. Now, diabetes, obesity, and cancer, we can see that increased adiposity can cause certain changes in certain mediators. So there could be an increase in leptin, an increase in inflammatory markers, increase in the bioavailable estrogen, which can increase the mitogenic signaling and tumorigenesis. When coming on to this adiponectin actually has a protective role. It's an adipokine that reduces the level of free fatty acids and improves the lipid profiles and decreases the inflammatory cytokines. So when you have obesity, the secretion of adiponectin is reduced, and hence you have a effect on the progression on tumorigenesis. So the effect of metformin and other anti-diabetic drugs will be actually discussed by our next speaker. So I'm not going to brief on this, but as such, they have found that metformin has been having effect in reducing the tumor growth and reduces the risk of certain cancers. So what is the conclusion that we come from understanding or learning about these pathophysiology? Now, there is a possible risk, and we need to do some potential interventions. Now, this is a Gordian knot, but it can be solved through conventional, unconventional methods. So we need to really take up some drastic step to solve this Gordian knot. And the potential requirements or interventions needed are, we need to go and optimize cancer screening adherence. Clinical screening is a must at diabetes diagnosis. Risk factors needs to be eliminated, like in case of obesity, and you can even modify your dietary intake. And further research is definitely required in this area. And I thank you all for the patient listening and giving me this opportunity to learn about this topic and share whatever I've learned. Thank you so much.
Thank you, madam, for an excellent presentation and making us understand the pathomechanisms. And I personally say I have learned a lot from your presentation. So we all are well aware that IGF is one of the culprits leading to all these things, and hyperinsulinemia and insulin resistance in diabetes is the key factors, and various mechanisms are now being developed to target this IGF-1 which not only promotes cancer, and it also affects in other ways also. And various drugs like metformin also act through the same pathways. And nowadays we are looking for calorie restriction, which also helps in reducing IGF. So I'm not taking much more time. Once again, congratulate you for an excellent presentation, and we'll hear more from our next speaker on this role. Thanks, ma'am.
Thank you so much, sir, for chairing the session and sharing your thoughts on this topic. And thank you so much, ma'am, for such a power-packed lecture. And you have explained beautifully the pathomechanics at cellular and molecular level. Thank you so much, ma'am. Over to you, Sangeeta, ma'am.
Thank you, Dr. Gunjan. There was excellent deliberations given by the speaker. Now we move on to the last lecture of the webinar. And for this, we would like to invite the chairperson, Dr. Ashutosh Nirula, please. Dr. Nirula is a distinguished guide and mentor for the students at the Postgraduate Institute of Lakshmibai Dental College, Patiala, and he's heading the department since past 14 years. He has a career spanning over 28 years, and he has been a spine in shaping the academic and professional standards of the students at his college. His unwavering commitment to excellence and dedication to nurturing budding professionals makes him a true inspiration in the field of dentistry. Over to you, Dr. Nirula, for the introduction for the next speaker, please.
Thank you, Dr. Sangeeta. Thank you so much. I'm really honored to have been, thanks to you, Dr. Sangeeta, who have been pushing all of us for maintaining those standards. Thank you so much. Today's topic, webinar on diabetes and oral cancers, and of course on the drugs also. I would like to invite Dr. Agarwal, who is a director and consultant diabetologist and of Dharma Diabetes and Metabolic Clinics, Delhi. And he's also a consultant in diabetes endocrinology at Fortis Hospital also. He's a fellow Royal College of Physicians, Edinburgh, and the Fellow of Royal Society of Medicine also. He is the executive member for the International Society of Renal Research, Metabolic Obesity, and Physicians and Clinical Endocrinologists, and president at Dharma Diabetes and Health Foundation. Member of Research Society of Diabetes India, Endocrine Society of India, and American College of Physicians, Healthcare Panels of India and Delhi. He is recipient of Pharma Leaders Award for Most Innovative and Admired Diabetologist in India. Published over 16 national and international publications in index journals, and he is the chief and principal investigator on multiple clinical trials and studies. He is also the editorial board member at EC Diabetes and Metabolic Research Journal and reviewer at Open Access Journal of Obesity and Metabolic Disorders. A clinical and academic mentor for fellowship in diabetes courses by Midwifery, accredited by Royal Liverpool Academy, UK. Also, and NHS Health Education in UK. And is organizing committee member for an invited speaker and faculty at several national and international medical programs at the conferences. So I welcome Dr. Mudit Sabharwal to please give a presentation on metformin, which is an old drug, and their therapeutic possibilities. Thank you so much.
Thank you so much, sir, for introducing me. Thank you, Dr. Sangeeta, for inviting me for this prestigious session and prestigious event. And I'll just share my screen and we can probably go ahead. Yeah. So without taking much time, I'll be talking about the metformin and the anti-cancer as an anti-cancer therapeutic. And we know that metformin is a staple drug which we have been using for last many decades for diabetes management. But then let's understand how does it actually help in as an anti-cancer therapeutic and not just an anti-diabetic. So objectives of my presentation today would be to explore the oncology potential of metformin and to understand metformin role, that how metformin transitions from diabetes management to oncology. Again, unpacking the mechanisms where I'll be explaining about exploring the molecular pathways metformin influences in cancer. And again, some reviewing clinical evidence that will summarize the key studies, trials, and real-world evidences around the same. Well, to introduce again, this is basically a staple drug and has been and also been emerging as an anti-cancer agent in combination with a conventional oncology practice. Well, the discovery and primary use was basically for treatment of type 2 diabetes. It was absorbed in the gut, and again, it's primarily excreted unchanged by the kidneys. And of course, it is one of the most widely prescribed and cost-effective drug globally. Probably it is available everywhere in the world, and has been probably one of the cheapest and the most available resource for anti-diabetic as an anti-diabetic agent. Well, of course, the linking diabetes, metformin, and cancer risk. So again, diabetes and cancer risk has already been established by the previous speakers and has been detailed out clearly detailed out by the previous presentations. Again, there is hyperinsulinemia and insulin resistance that, of course, elevate cancer risk in diabetes patients. There has been observational data where studies suggest that about 20 to 30% reduced cancer incidence in metformin users were found to be compared with non-users. And again, the key cancer types which were benefited by metformin intake were breast cancer, colorectal cancers, and pancreatic cancer that show significant associations, and we'll be discussing them in the future slides. Well, of course, there are direct and indirect pathways. So direct pathways include AMPK activation, mTOR inhibition, and cell cycle arrest. Indirect effects generally include reduction in insulin, glucose levels, and inflammatory cytokines. And of course, there are broad spectrum impact where mechanisms target tumor metabolism and microenvironment around the tumor to actually reduce its growth. Now let's understand each pathway and each system as per se. So again, the we're talking about AMPK activation, where metformin's role in tumor suppression is clearly established. So it's basically three pathways. One is a cellular energy regulation, where AMPK acts as a cellular energy sensor and metabolic regulator. Inhibition of tumor growth, where it disrupts ATP production in cancer cells, inducing apoptosis. And again, it also inhibits the lipid and protein synthesis that is critical for tumor growth itself. Now, moving on to mTOR pathway, where metformin impacts the tumor growth itself. So again, the role of mTOR is basically that it's central to cell growth and proliferation, and again, hyperactive in many cancers, which is basically directly affected by metformin. Well, how does it happen that metformin downregulates the mTOR signaling by halting the tumor progression itself? And again, the induction of autophagy and reduction of protein synthesis in tumors further regulates and reduces the tumor progression itself. Now, it also leads to reduction in insulin IGF-1, and that has been explained by the previous speaker in detail. So again, this is basically targeting the drivers of tumorigenesis, where insulin roles, so where hyperinsulinemia promotes tumor cell growth and survival, where again IGF-1 amplifies signaling cascades for proliferation. And again, metformin is basically lowering the systemic insulin and IGF-1 that also leads to reducing tumor promoting factors and tumor promoting effects of both the pathways. Hence, it basically it also down-regulates the tumor growth and proliferation. Now again, how does it affect the tumor microenvironment, which is also modulating the cancer ecosystem itself by three major factors? Well, first is the anti-inflammatory effects, where it reduces pro-inflammatory cytokines, limiting the tumor progression itself. It also impacts on angiogenesis, where it inhibits the VEGF signaling, reducing the blood supply to the tumors. So hence the tumor cannot progress itself. And again, cancer stem cells it targets the cancer stem cells by reducing the recurrence risk of the same cancer. Now, talking about some clinical evidences and studies. So again, there are retrospective and observational studies which were also mentioned before. So again, there has in breast cancer, the meta-analysis revealed that about 25% lower recurrence was found in metformin users. In colorectal cancers, the epidemiological studies have been done, which shows reduced incidence rates by 20%. And also in pancreatic cancers, with improved survival in early stage patients using metformin was clearly observed in the studies and published. There has been some RCTs, real world randomized controlled trials, where evidence from control studies clearly shows that phase 2 studies show an improvement in outcomes in metformin users in breast cancers. Ongoing trials has been there to evaluate the efficacy of precancerous lesions like lichen planus, etc. And that has been clearly discussed in the previous presentation, so I'm not going in detail. So again, which basically helps in oral cancer prevention. And again, there has been some limitations where heterogeneity in study design were there, and of course it needs phase 3 validations itself. So the combination therapy, as I mentioned in the previous slide, is generally found to be effective. So again, it's synergistic with the existing treatment for chemotherapy, immunotherapy, and radiation therapy. So with chemotherapy, it enhances efficacy of standard chemotherapy regimes. With immunotherapy, it boosts the immune system response to tumors, the body's immune system response to tumors. And with radiation therapy, it improves the radiosensitivity in certain cancers, which I just mentioned in the previous slide. Of course, talking about specific cancer types where metformin efficacy was found to be evident. With breast cancers, which I just mentioned in the previous slide, there was reduced recurrence in mortality itself by about 20 to 30% in diabetes patients. In colorectal cancers, observational studies indicate about 24% lower incidence rate. And in pancreatic cancers, basically improved survival in early stage pancreatic cancers, which were clearly evident in the studies. Well, there are some potential side effects. So again, the most common side effects are gastrointestinal issues like nausea, diarrhea, and abdominal discomfort, which is usually mild and transient in most of the patients. There are also been found vitamin B12 deficiency, which is generally happens in long-term use of metformin. That may lead to deficiency of vitamin B12 and again requiring periodic monitoring and supplementation. And some rare side effects, but not so rare now, are lactic acidosis, where a severe but rare risk primarily in patients with impaired renal functions has been found with metformin prolonged use. Well, considering everything, the whole presentation as per se, so they're integrating metformin into cancer treatment provides adjunct use in diabetics. So again, clinicians may integrate metformin with traditional therapies, especially for diabetes patients. In non-diabetics, where careful clinical judgment is required due to limited data and of course potential risks, which I just presented. And again, personalizing medicine is very critical, where potential of tailored approaches based on genomic profiles and cancer types play a very, very critical role. Well, of course, future directions include innovations and research horizons, where novel formulations developing metformin derivatives with enhanced cancer activity can be used. And of course, making the whole medicine more precise, where identifying patient subgroups are most likely to be benefited by use of metformin. And again, it can also be used or explored in cancer prevention, where exploring metformin's prophylactic potential in high-risk populations can be utilized. From my side, there are only 3 take-home messages and the key learnings on metformin in oncology. So first is broad spectrum potential, where efficacy across multiple cancer types, particularly breast and colorectal cancers, has been established in some studies, but again, further can be further studied and used. Again, it's affordable and accessible, mostly accessible and affordable by most of the patients in the world. So again, it's low cost that makes it viable globally, especially in resource-limited settings. And again, there are some critical knowledge gaps where future research is needed for optimal dosing and patient satisfaction. Thank you. Over to you, sir.
Agarwal, a nice presentation, nice knowledge about metformin and its benefits as well as side effects. I would like more studies are being conducted for oral cancers as well as precancerous lesions. But to head over to Dr. Sangeeta again. Thank you so much, Dr. Mudit.
Thank you, Dr. Nirula, for chairing the session. Dr. Mudit, I think this was a very detailed insight, though it's like a nascent stage, I would say, but still there is a lot to talk on it in the coming years, possibly. And simultaneously stay put, because there are questions specifically for your talk only. We'll be rolling it over. And do we have any questions now from the faculty on the platform right now? Dr. Whittle, would you like to add something?
Yeah, basically, Dr. Sangeeta, I must congratulate Diabetes India as well as you for heading the oral health group, interest group. And I think it is high time that we integrate oral cancer screening with diabetes management program, especially India being high prevalence area. So we can have, the conventional as well as the major risk factors like tobacco, alcohol use, obesity, poor oral hygiene to be integrated and noted that whether these are in fact related to generate data as well as public awareness. So we should strive toward, like you have already initiated one study for oral hygiene and diabetes. So I think one more study for oral cancers, or what you feel like the other factors related to oral health and diabetes should be initiated to generate Indian data.
Right, sir. Perfect.
Thank you.
Dr. Mudit, there's one question from my side. Dr. Mudit?
Yeah, ma'am, please tell me.
Okay, so I just need to understand the type of cancers which you had stratified, typically which are being applied in terms of documentation. Now, let me understand regularly in the Indian scenario, are the oncologists taking metformin as a drug of adjunct drug in their cancer therapies? Are they actively doing it, or it's still in the early stages?
No.
Ma'am, as I just mentioned, and Dr. Vittal already answered your question, I suppose. So yeah, so that's not the case
So
here.
basically, you have to have a very open mind to accept. So generally, they think it is a anti-hypoglycemic agent. So they will not even go for studies also. That is why India lag in studies as well as openness. So if you tell any cancer specialist that why don't you try metformin, he will not listen to you. What about the existing data or anything, or curiosity wise also?
Right.
So that is what is lacking.
Dr. Mudit, Dr.
Yes,
Mudit, I was going through a meta-analysis of metformin as a role for anti-cancer drug, and that says ki if it is used below 18 years of age, it has a positive effect, and above 18 years, it doesn't have that much effect. How true it is this? I was surprised to see that analysis. So that was one controversial part of it.
So there are many controversies. That's why I said ki, there has been meta-analysis and there has been very controversial meta-analysis. I believe that I have read the meta-analysis you're talking about. The point is that yes, because above 18 years of age, probably the use of metformin is more common, and probably that is why it is studied more. There is no specific reason which was mentioned in that meta-analysis also. Yeah, so it's basically use were done in type 2 diabetic, probably adult patients with insulin resistance. So probably that is the reason.
And we hardly use this drug in below 18 years of age.
Absolutely.
So I was wondering who is using it in younger age group, and
Yes,
why
sir.
this study was done. So anyhow, it needs to be explored in more studies.
And
So
may I
basically, if you go by the literature, the meta-analysis also, you can have a bias or you can mold or in a specific direction. So
That's
you
true.
need to have lot of studies and meta-analysis to find out a conclusion, in fact. So there is a lot of bias in meta-analysis, various meta-analysis and methodologies also.
Sir, can I add one thing?
Yeah, please, sir, please.
Sir, I have recent experience of using metformin cancers. My elder uncle, he was on metformin for almost 2 grams for last 16 to 18 years. When I did my MD, he was just diagnosed as a diabetic, and he was introduced on metformin 2 grams by me. He is still well controlled on diabetic for last 16 to 18 years. But in the last year, he developed brain malignancies, that is a GBM. And after all the surgeries, radio, chemo, he had a recurrence of the same thing. So, and another example I have seen in 5 or 6 patients who was on metformin full dose, well tolerating, blood sugar was well controlled. So, real world scenario, real world evidence, we can't say whether it's a metformin really preventing or it has some theoretical role. But I have said in my practical experience, though I also mentioned that it is may have preventive role in some solid organ tumors like lung or the brain or the ovaries malignancy. It was also mentioned in so many literatures. We are reading and discussing in so many conferences over last 5 or 6 years. But it's still real world as far as my personal concern or the reason, I can't believe on this.
Sir, it is just to answer your question. You're absolutely right. The studies which have been done, they are done on specific cancer types. So it's basically either colorectal cancer or breast cancer or somewhat prostate cancer. And probably Dr. Khurana was also mentioning the meta-analysis that also included the same kind of cancers, prostate cancer and colorectal cancer. The whole reason for that is that metformin basically works for as in 4 different pathways. One is improving insulin sensitivity, and as we know that obesity itself and insulin resistance itself works to promote the progression of these kind of cancers. There's anti-inflammatory effects, which basically helps in lowering the inflammatory cytokines TNF alpha and IL-6, where metformin helps in that way. There is AMPK activation, which I just explained, and also the inhibition of mTOR pathway. And of course, there is adiponectin regulation. So, and gut microbiota modulation. So, in these ways, these are the only cancers which have been studied for metformin. And of course, it is still being studied, and it's not something which has been probably looked upon as a research topic by oncologists in general. So probably these are all meta-analyses, but then of course it's open for discussion.
But at the same time, Mudit, now we are listening that you have been reading also in newspapers and various articles that if you don't give sugar to babies till 3 years of age, the chances of diabetes are very less. So that can be one preventing factors also for oral cancer. I might tell you there will be a link in that also, because if you very early stop the sugar in the kids, so it is going to help in preventing hyperinsulinemia and insulin resistance later on, which develops much, much earlier before developing diabetes, which we see in 16 to 18 years of age. So that can be one of the preventive factors.
Absolutely, sir. I totally agree with you. In fact, childhood obesity is a problem now, and that the major reason for that is that start of sugary, I think sugary snacks have been very, very high. Intake of sugary snacks, especially post-COVID, that has been very, very high. It has also affected the brain and the mental development of the kids in every reason, right? So, and in every aspect. So, insulin resistance probably plays a role. So, of course, what you're saying, I completely agree with you.
Right. So we do have some questions for you specifically, Dr. Mudit. So let us just shoot it one by one for you. So let's begin with the participant asks us, how does the use of metformin beyond being an anti-hypoglycemic agent such as in obesity affects its cancer protective effect?
So I think, ma'am, I've already answered that question in the discussion. Yeah.
Right. So the next question is, the participant is asking, could you please enlighten us with the role of zinc oxide nanoparticles in diabetes?
Well, thank you for the question, ma'am. I suppose it's the antioxidative properties and anti-inflammatory properties of ZNO that basically helps in reducing the oxidative stress and, of course, reducing the inflammation as per se. And of course, it helps in improving insulin sensitivity because of the above factors. In a similar manner, it also helps in beta cell protection and somewhat regeneration, blood glucose regulation, because it enhances the glucose uptake and metabolism, controlling overall hyperglycemia. In somewhat, of course, it also helps in wound healing because of its oxidative properties, particularly in diabetic ulcers. We have seen in some patients who have improved in diabetic ulcers who've been put on ZNO, and again it basically works by stimulating the cell proliferation and antimicrobial activity properties. But there are some safety concerns. So again, toxicity may happen, but generally, if it's prescribed by a physician in a probably controlled manner, then of course that is not a problem.
Right. Now there's a third question that comes up now, ever since we do have a dental audience also in this webinar. So we have, I mean, I'm sure you're aware, there's a local drug delivery system which is quite popular, in a management of periodontal diseases. Now the delegate question goes as, can metformin be utilized? Obviously, it's a far-fetched thing that we're talking, to be applied as a local drug delivery system at some point in time. What is your thought on it? As a molecule, can it be somewhere?
Well, I'm not sure about it because it's never been tried. So again, as you said, it's a long shot. So I'm generally
Because
not sure.
the protective activities that the properties that the molecule is having, perhaps, somewhere can it be an adjunct therapy probably. So
Well, it can be given as an oral agent. So that is, I don't think that's a problem, and it should be given.
as an oral will be a systemic effects, no? So local drug would be a targeted delivery system is what we're looking at, because we do use many molecules.
Well, I suppose, ma'am, if in case that's possible, then I think the antimicrobial or anti-inflammatory or tissue healing properties, especially the oxidative properties, can be utilized.
Right.
And of course, of this agent, it's a beautiful agent. It's a very good agent. But I don't think anyone has tried that before.
It's a newer arenas are opening up as we are talking. So obviously, multidisciplinary, approaches to utilize the molecules cross disciplines is what we're saying. Dr. Nalini, would you like to add or comment on any of the topics?
Actually, there are some studies, I'm not very sure, on local application of metformin, and they have even reported there's some bone forming capacity, but I'm not sure. The literature, I don't remember, but I think it's already been being evaluated, I think so, ma'am.
Right. So it's like a little early stages, probably what we're talking.
Early stages, yeah, because we always, sir, because we never achieve, when we take systemic antibiotics or any drug, we don't achieve the sufficient concentration in the gingiva, the area where we need it to work. So we always work on local drug delivery. So somebody has worked on it, but I'm not sure about the effect.
So possibly after 10-15 days, we host this same topic, we might have some evidences probably.
Yeah,
what
definitely.
we are talking today probably.
Definitely, ma'am. Thank you so much, sir.
So
Madam, I have one question. I have one question again.
Yes, sir, please.
So we see patients of submucosal fibrosis. They come with small opening of their mouth, which is very common in people who chew betel. So do you come across such patients? Are they, you have told in one of your slides, and Dr. Lisa, I don't know who was the speaker, who told us that this is a pre-malignant condition. So how frequently it turns into malignancy? I have seen few patients, but they are all betel chewers. They were taking that type of, क्या बोलते हैं उसको जो सुपारी होती है, and there is very difficult. So any experience of yours, anyone? Because you guys deal more with such type of patients.
Dr. Gunjan, would you like to comment?
Yes, definitely, ma'am. Very well asked question, sir. Sir, we get a lot of patients of OSMF, oral submucous fibrosis, and yes, it is a pre-malignant lesion. So if we do not treat it in time, I mean, if we have diagnosed it and if we give the treatment to the patient, then we reduce the chances of patient to get converted into an oral cancer. But if the patient reports very late and we do not treat that problem, so yes, definitely it can lead to a cancerous lesion. So yes, it is a very significant pre-malignant lesion and it can be diagnosed very easily by the dentist. And the patient also, gives very early signs of the problems which he faces because of OSMF.
Yeah, we do 2-finger test. We put finger in.
Exactly. There is very less mouth opening. So patient comes, quite frequently to us in our dental clinics. Most, commonly in our dental colleges, we encounter a lot of patients. Like once in 2 days, we definitely see a OSMF patient, because here in our belt, the patients are, chewing a lot of tobacco, pan, supari, gutka. So it's a very common finding here.
So
basically,
any other relation apart from this, anyone without?
Your voice is not clear. Yeah.
Hello.
Yeah, please.
So basically, the local application came as a question. So I think there are evidences that local application may have anti-inflammatory, anti-proliferative, and wound healing properties.
So I wanted to mention, yes, definitely there are not few. I would say there are like many articles which I have read myself on metformin as a local drug delivery agent. Yes, we are giving it.
Treatment.
Yes, we are giving
healing, especially an oral cancer therapy for local application as a paste.
Yes, definitely, sir. So we mix it with some substrate and we place it in our periodontal pockets, and it has been seen that it induces anti-inflammatory effects and it causes healing of the periodontitis and other gum diseases in the
Yes,
oral cavity.
maybe in India the gel is not available. I think we should search the literature
Sir,
whether
many
in Western countries gel
so
is available.
many colleges are formulating in their own pharmacological labs in India. The colleges, when they are
Yes.
doing their thesis work and dissertation work, they are formulating by taking the support, by taking the help of the articles which have been published out of India. So they
Yes.
make it their key article, they take the references from there, how to formulate it by all the pharmacological means, and they are doing the trials on the patient.
So
Yes, it's being done.
this is another area which should be explored extensively.
Sir, or dentists are definitely doing the periodontists, but the medical field side, they are unaware about these
So
facts.
that is why collaboration is very, very
Of course.
important, you know.
Yes,
So I
definitely.
must congratulate Dr. Sangeeta to make this happen. So there should be diabetes and oral health clinics. So where we should explore local application because it is quite economical medicine as far as oral application is concerned. And we should
Absolutely, sir.
explore the exact potential of metformin as local application.
Right,
Definitely,
right,
sir.
Right, sir. Any other questions from the faculty? If not, then we probably will be just reappear everybody so that we can just kind of, wrap up the session if they are there, because it's approaching the dinner time. I think people would have. Yeah. So thank you all for this wonderful.
You should have arranged a virtual dinner also.
Absolutely.
Right?
Next time we'll keep that in
So
mind.
then everybody will be present over dinner.
Great. So thank you all for your participation. It was a lovely interactive session, though it's a topic on the nascent levels, I would say. But then, yes, there is enough to explore, and possibly sometime in the coming years, we do have some more documentation and more evidence to talk about it. So for now, we'll be saying bye to all, and we'll be sharing your participation certificates over the mail. And delegates, we have already posted the message for you all. Please download your certificate of participation from the download link, which will be active after the webinar. And till such time, and we'll be connecting again. So hopefully we'll be meeting few of you next week for our Diabetes India Symposium. So if you have time, kindly join us. That will be a pleasure to have you all over.
Madam, it was really very tough for the speaker to make such slides and do the presentation. Hats off to them, and three cheers to all the speakers.
So it's good now when you put in some efforts. That's the beauty of it. Yeah.
It was not an easy topic.
So
congratulations to all the speakers.
To all the speakers, yes. Big effort to compile the whole and present, and we learned a lot. Some new informations actually. So thank you all.
Thank you.
And good night. And we connect again at some different platform again. Yeah.
Okay.
Thank you all. Thank you so much. Thank you, Sagar. Thank you, Sagar, for the good backup.
Thank you. Thank you, everyone.
Thank you, ma'am.
Thank you, and stay blessed. Okay then. Bye-bye.